She's a known diabetic and hypertensive on medication. She doesn't have any history of coronary artery disease, asthma, thyroid, or seizure disorders. There's no past surgical history, no history of drug hypersensitivities, or she's not on any antiplatelet medication. On physical examination, she was of short stature, vitals were stable, airway was good. Investigations, X-ray revealed a trochanteric fracture of left femur. Her hemoglobin was 8.8 gram percent. Sugars were on the higher side, GRBS 198 milligram per DL, HbA1c was 7.5. ECG showed T inversions in chest leads V2, V3. 2D echo EF was normal. Grade 1 diastolic dysfunction, aortic valve sclerosis was present. Rest of the reports were within normal limits. A cardiologist opinion was taken for fitness of surgery, who advised to do a CT coronary angio in view of diabetes, age, and ECG changes to rule out any silent CAD. But since the patient attenders were not willing, she was given moderate risk for non-cardiac surgery with heparin backup. Patient is posted for ORIF with proximal femoral nailing of the left femur. Pre-op orders were given, 2 points of Paxil were reserved. Telmisartan, which she was using, was withheld on the morning of surgery. Anesthesia part, under strict aseptic precautions, spinal was given with bupivacaine and dexmedetomidine. Co-loading done with normal saline. The level was T10 after 15 minutes. Patient was comfortable, catheterized, and then positioned. Intraoperatively, PF nailing was done under strict aseptic precautions. The surgical time was 2 hours. Vitals were stable intraoperatively. BP maintained at 110 to 130 mmHg with 10 mg of ephedrine intermittently. Saturation was 100% with 2 liters oxygen. Estimated blood loss in the surgery was 200 to 250 ml. IV fluids given intraoperatively is 1.5 liters. The 4th point of normal saline was on flow. The urine output emptied was 700 ml. In the immediate post-op, patient was shifted to post-op ICU for recovery. When connected to monitor, the ECG showed atrial fibrillation with a heart rate of 156 per minute. On examination, the patient is completely asymptomatic, conscious, coherent, following commands, no complaints of palpitations or dizziness or chest pain. Her pulse was irregularly irregular. BP was 90 on 60. Chest was clear. ABG was done, which showed metabolic acidosis with a bicarb of 18. Sodium and potassium were 137 and 4.2 respectively. 2D echo was done, which showed a fair LV and an IVC of 1.47 centimeters. After confirmation of AF in the 12-lead ECG, the patient is reassured, attenders were counseled. Injection noradrenaline infusion was started. Blood transfusion was started to compensate for any blood loss intraoperatively. Injection amiodarone 150 mg slow IV was started after the systolic BP increased to 110 mmHg as advised by the cardiologist. After 1 hour, patient was comfortable, still no symptoms. Injection amiodarone was given. Vitals were BP 130 on 90. Heart rate 150 per minute. AF is still present. Blood transfusion was on flow. Injection noradrenaline infusion on flow. After 2 hours, patient still asymptomatic. Paxil transfusion completed. Noradrenaline was weaned off. Spinal anesthesia was wearing off. Vitals were stable and her heart rate was 86 and reverted to normal sinus rhythm. Maintenance fluid was started at 100 ml per hour. On the first post-operative day, patient was comfortable, normovolemic, and off IV fluids. Repeat hemoglobin was 8.8 gram percent. So second point of Paxil transfusion was given. Endocrinologist was on follow-up for diabetes. Prophylactic injection Clexane was started. Patient was discharged in hemodynamically stable condition with a hemoglobin of 10 gram percent on the third post-operative day. I would like to ask the cardiologist in the panel, are there any ECG changes that we can detect on the monitor before occurrence of AF?
I didn't get your question, ma'am.
Are there any ECG changes that can be detected on the monitor before the occurrence of AF, atrial fibrillation?
No, the rate irregularity only we can detect. Are you specifically asking any markers in the pre-procedure ECG?
Yes, sir, like prolongation of P wave.
No, the risk factors we can make it, or like elderly, female, CKD, history of hypertension. So those are the subset of the patient where there increased risk of development of atrial fibrillation.
And which is better for thromboembolism prophylaxis, sir? Direct oral anticoagulants or vitamin K antagonists?
No, that depends upon the subset of the patients. If it's a non-valvular atrial fibrillation, we can give either, but if it is in valvular, then we have to use the vitamin K.
Yes, sir. And any role of prophylactic amiodarone that can be given in high-risk patients for elective cardiac and non-cardiac surgeries. Role of prophylactic
No,
amiodarone.
there is no role prophylactic. All the studies done were negative only. There is no prophylactic loading of amiodarone in any patients to prevent the postoperative atrial fibrillation.
Yes, thank you.
Thank you.
AIs can predict, it seems, nowadays. ECG read by AIs, they can predict. And other, maybe if you are watching the monitor, frequent atrial ectopic starts coming, then you can check whether something is going wrong which is causing that. Otherwise, that is maybe a precursor for AF. Otherwise, pre-op ECG means AI.